Okay, well, thank you all for joining us this Tuesday for our Dementia Care Aware webinar for the month of May. We're pleased to present a deeper dive into adapting the cognitive health assessment for patients with serious mental illness. And our presenter today is Steve Huege, and he's a clinical professor in the Department of Psychiatry at UCSD School of Medicine. We're really pleased that he's part of our DCA team in San Diego. We're so lucky to have his expertise and particularly his intensive time on this webinar today. As you know, I'm Anna Chodos. I'm the director of the Dementia Care Aware program in collaboration. We're very fortunate to be in collaboration and realizing this program for the Department of Healthcare Services. And my other day job is as a professor in the UCSF Department of Medicine in geriatrics and internal medicine. And I'll be moderating today's session. Neither of us have any financial disclosures to make today. And as usual, we start off as people continue to gather on the webinar, just to remind you about our program. As you can see, there's also a QR code behind me here. But just want to remind you that our Dementia Care Aware program offers both support for implementing the cognitive health assessment and dementia screening, assessment, and care into primary care. We also offer and are very proud to bring you these educational opportunities, as many of which offer continuing education credits as possible. So we have our trainings, including these webinars and our podcast. We have our live cognitive health assessment trainings that are also rolling out, and you can find those on our website. And what that means is that you can sign up for something like this, either in person and regular virtual live trainings to get people trained on the cognitive health assessment. And then we have our online trainings. Right now, the primary one is the cognitive health assessment training, and really very shortly we'll have more rolling out, and we invite you to sign up for our listserv via our website or email us for more information about that schedule. Things like this topic will then be on the online platform, and you can learn at your own pace and get credit for it. We also have interactive case conferences, which you can find out more about and sign up for. These are echo-style case conferences, which really work with people in clinical practice to learn about how to implement screening and how to take care of people who are living with dementia. And then we have innovative things like the Warm Line, which is a 9 to 5 Monday through Friday service for real-time support for dementia care. You can talk to a live dementia specialist or other consultants in dementia care. And we have really world-class practice support from the Alzheimer's Association and the UCLA Alzheimer's and Dementia Care Program. They can coach your practice and providers through how to do dementia care and help get your practice dementia care ready and friendly and capable. A reminder that our key training on the cognitive health assessment, which is sort of the foundation of a lot of what we've been talking about in the webinars and the whole program, that's available, and you get 1.5 continuing education or continuing medical education credits by doing the training. It's at your own pace. It's available via our website. I have one tiny and unfortunate caveat today, which is we just did a website update, which I do hope you'll check out. But unfortunately, this exact training is challenging to access at the moment, and people are actively working on that. It just happened to be poor timing this week and should be solved within a matter of hours. So my apologies, but I do hope you'll check it out or do the training another time after this webinar. So again, the foundation of this program is a cognitive health assessment. So I'll review it here briefly, just so we're all on the same page and we know what we're talking about. Cognitive health assessment is an annual screening approach for people 65 and older that uses validated tools. And so the goal is for us to screen our patients 65 and older in primary care annually, who don't already, of course, have a diagnosis of dementia and who otherwise would benefit from the screening, meaning perhaps if they have a life-limiting illness or are in hospice, they wouldn't necessarily need this screening. But for everybody else, we recommend this approach, and we teach you how to do it in the trainings. First, take a brief history, which is often just a question. How has anybody noticed, or have you noticed changes in your thinking or memory, for example? That could be the history. Part two, implement a validated screening tool for cognition and function. So cognition and function being the two key components of making a dementia diagnosis and detecting it ultimately. So we give you tools and training on how to do those validated screens. And lastly, a very brief review of the person's support system. And the pillars we want to emphasize and what our discussant is going to talk about today is how you might modify some of this approach or think about this approach in our patients with serious mental illness. But the care partner information is, of course, very important regardless, and particularly if people are having symptoms of cognitive or functional decline. So just a brief overview of the approach. And then if we do detect a positive symptom or there's a positive screen, this gives us the opportunity to start a brain health plan as soon as possible to help address those symptoms, improve brain health and any possible chance of progression if the person does have dementia, and to really be active and involved in that person's care plan around cognitive and functional decline. So thank you so much for doing that review with me and us all getting on the same page. So honored to pass it to our discussant today, Dr. Huege, to talk about how we can adapt this approach. Thank you so much.
Thanks so much, Dr. Chodos. I'm really excited to be here with you all today. Just kind of reviewing the learning objectives for our presentation today. First of all, we'll talk about how to understand the challenges that are faced by older adults with serious mental illness. Looking at some of the unique issues that this population faces. We'll also look at identifying ways to adapt the CHA to older adults with longstanding and serious mental health conditions. So what are changes or adaptations that you may need or may want to do with your older adult SMI population? Also recognizing the social support needs for older adults with SMI, how those might be different than patients without serious mental illness who maybe in your patient population, recognizing some of the unique changes that are there. And finally, adopting treatment strategies for older adults with co-occurring SMI and cognitive impairment, right? What are some strategies and modifications that might need to be put into play when you're working with this sort of dual occurring population? Next slide. So we'll talk a little bit about just some background issues. Next slide. So what is SMI or serious mental illness? The definition is actually quite broad, and there's a variety of different entities and places that kind of think about what constitutes serious mental illness. Actually, in researching this for this talk, what I found is that actually the state of New Jersey in their code actually has a definition that is often widely accepted, and which I think fits with a lot of the other conceptualizations of serious mental illness that I've seen, that I've encountered both in work and in the literature. So first and foremost, for serious mental illness includes, but is not limited to, the following diagnoses. So schizophrenia, schizoaffective disorder, delusional disorder. So conditions that we typically fall under the rubric of psychotic disorders, where there is some impairment in reality testing, along with the possible presence of delusions or hallucinations. Also, significant mood disorders, so major depression, bipolar disorder, and also certain personality disorders can also fall under the realm of serious mental illness, including schizotypal personality disorder, borderline personality disorder. The differences with personality disorders that these are more long-standing characterological traits, as opposed to the typical, what we used to think of as axis 1 psychiatric conditions, so things like schizophrenia, schizoaffective disorder, bipolar disorder, that are more episodic, generally speaking, in nature, although these conditions certainly can be lifelong with a relapsing and remitting course. But it's important to look at the entire context of the patient's condition. We'll talk more about that. Next slide. And then importantly, when we think of folks with SMI, we also need to take into account that it's a population that has severe mental health needs. So again, going back to the state of New Jersey requirements, number one is that the patient has to have a current diagnosis of a serious mental illness, as noted previously. Number two, they have to require active rehabilitation and support services to achieve the restoration of functioning, to promote the achievement of community integration and valued life roles in social, employment, educational, or housing domains. And then finally, number three, they either have to be currently functioning at a level that puts the consumer, the patient, at risk of hospitalization or another intensive treatment setting, or they exhibit deterioration in functioning that will require that they be hospitalized in the absence of community-based supports and services, or they do not have adequate resources and supports to live safely in the community. So again, as you can see, this is a particularly vulnerable population. And oftentimes many of our patients with SMI are really quite vulnerable and operating sort of on the margins or fringes of society in some ways. Oftentimes these folks have significant housing, difficulty obtaining stable housing. Many of them are unhoused, or sometimes too, patients with who fall into this population will have limited social, financial resources. Again, we'll talk more about that. Now, the interesting thing is that when you sort of have patients with SMI, and how does the aging process play into that, right? What happens when you sort of have this convergence of the aging process and patients with a history of severe mental health needs? As we'll see on the next slide, and hopefully the reason everybody is here today is that ours is an aging nation, that what we are seeing is a significant demographic shift that is really unprecedented in our history. And what we're seeing is that we are approaching an inflection point within the next 10 to 15 years, where adults over the age of 65 will outnumber, as a proportion of the population, children under 18. And again, as you can see, this is unheard of in our history. Now, there are a number of countries, particularly Western Europe, places like Japan, where this demographic shift has already occurred or is going to occur sooner. But this has significant implications for society and for healthcare policy and planning, that really for the first time ever, we are approaching a point where there will be more older adults than younger people in this country. Next slide. And then what we also see is that that this population, the older adult population, that this is some interesting data, actually from the UK, that looks at the prevalence of severe mental illness in patients 15 to 74 by sex, age group, and level of deprivation or socioeconomic need. And what we see is that men slightly outnumber women, and that as people get older, there's a significant bump from the 15 to 34 to the 35 to 54 age group. But what we see is that as folks get older, that prevalence holds relatively steady. And then also that if we look at sort of what they think of as deprivation or socioeconomic need, that the prevalence in the most, what they classify as the most deprived population is the highest. So what we see from this data is that one, that rates of serious mental illness are persist as people get older, and that again that this is further confirmation of the unique social needs and stressors of this population. Next slide. So I kind of like this schematic here. This is from SAMHSA, because it really, I think, outlines the intersectionality between aging and mental illness. As a geriatric psychiatrist, there's sort of two ways patients tend to fall into one of two categories. Either those who have aged with their psychiatric condition, folks who developed conditions like bipolar disorder, schizophrenia early in life, and then have progressed throughout their life needing treatment. And then often what happens is their psychiatrist and or therapist retires. And at that point, both they and their doctor sort of grew up together. And often the story is, well, my doctor's retiring and I'm in my 60s now, and they said I should see a geriatric psychiatrist. So folks who have kind of aged into geriatric psychiatry, and then also the other sort of bucket or category of patients are patients that have developed psychiatric symptomatology later in life. And there are some important differences between those two patients. But for the time being, this is looking at sort of, I think, that first category of patients, the patients who have had psychiatric illness and have required treatment over a long, extended period of time throughout most of their life. And what we see here is that, there's the intersectionality between depression, suicide, serious mental illness, substance use disorders, the impact of physical health, changes in physical health, and then risk factors, including low socioeconomic status, and underrepresented groups as well, who perhaps have historically been disadvantaged and disenfranchised by our healthcare system. And what we see is that long-term mental illness has significant impacts on all of the following. Includes physical health, so non-psychiatric medical health, social functioning and employment, income, levels of supports, housing, access to housing, and access to healthcare. And we'll see that, how these sort of converge as the patient gets older. Next slide. So, I think that this is a really important slide because it looks at, what are the features of health and healthcare for people with serious mental illness? And these are some things that have been found in the literature. And I think most of us are sort of at this interface, right, between aging, social factors, how the healthcare system, and aging with a longstanding psychiatric condition. What we see is that folks with SMI have higher healthcare costs. Their healthcare needs are often greater. And the unfortunate thing is that they often have greater difficulty accessing care. And if you think about too, how many of us now are providing care through some kind of electronic health record portal, if you combine sort of the impacts of longstanding psychiatric illness, social inequality, economic deprivation with computer literacy and healthcare literacy, what you can see is that it sort of creates this sort of perfect storm of converging factors that sort of together lead to things like we talked about, greater difficulty accessing care, difficulty contacting providers. I don't know if any of you have tried calling up your doctor, if anybody still does that. For the most part, San Diego, for example, we encourage our patients to reach out to us through the EHR portal, which again, for some folks can be quite difficult to use, right? It assumes that you have both the know-how and the technology, access to the technology to access those portals. Also, too, what we have found is that these patients are often less likely to have a primary care provider, so less likely to have somebody who is overseeing the entirety of their health care. And as a result of that, what we see is that they're more likely to go to the emergency department. And certainly our colleagues in the ED are doing great work, but it's not a substitute for a primary care provider who, and the hopefully long-term relationship that comes with that, and the understanding of a patient's entire history. What we also see is that there's greater levels of dissatisfaction with provider communications. And then finally, what we see, especially those of us in the geriatric space, what we see are higher rates of things like falls, congestive heart failure, COPD, and strokes, so higher rates of medical comorbidity. So again, not only do you have the challenges of having had the impacts of a lifelong serious mental illness, what you also see is the impact or the convergence of that with aging and accessing the healthcare system when you are really when you're most needing it. Next slide, please. This is just, again, prevalence of physical health conditions for SMI in all patients. So again, what we see is that, compared to non-SMI, and compared to all patients, typically what we see are higher rates of illnesses nearly across the board, including obesity, asthma, hypertension, diabetes, COPD, cancer, stroke, congestive heart disease. Again, this is data from the UK. But again, what we see is that having serious mental illness, lifelong psychiatric conditions, and the potential for estrangement and disenfranchisement from the healthcare system can lead to higher rates of medical comorbidity, in addition to the potential metabolic side effects of some of the certain kinds of certain medications that we use as well. Next slide, please. So speaking of treatments, the other thing too is that as people age, their ability to tolerate the medications that we have to prescribe for them changes. And what we see is that many of the, our psychiatric medications come with a host of side effects. And what we see is that the ability to tolerate or manage those side effects becomes more challenging as people get older, right? So, for example, anticholinergic side effects, which can include things like, cognitive impairment. Again, if somebody is already starting to experience some underlying neurodegenerative illness, taking a medication that further depletes your cognitive reserve can have a magnified effect on somebody who perhaps is younger, maybe has a more robust cognitive reserve. Also, things like dry mouth can impact dental care, constipation, particularly if severe and untreated, can lead to impactions, which further can lead to delirium. Problems with extrapyramidal symptoms, so Parkinsonism, particularly again for patients who may be developing an underlying Parkinson's disease or Lewy body dementia. The effects of tardive dyskinesia, which can result from long-standing antipsychotic use, the metabolic syndrome that we see from some of the atypical antipsychotics, weight gain, hyperlipidemia, hyperglycemia. Also to polypharmacy and drug interactions, right? Not just the number of medications that are being prescribed psychiatrically, but when you combine that with medications for other health conditions, you just multiply the potential for drug-drug interactions and problems. Falls and gaits. So again, many psychotropic medications are associated with increased fall risk, problems with gait. Sedation can be a problem. Again, many of the medications that we use can be quite sedating. And as we see as we get older, there's already changes and disruptions in sleep architecture. Quality of sleep can be impacted. Underlying neurodegenerative illnesses in and of themselves can also impair sleep quality. And of course, too, higher lifetime rates of smoking and substance abuse are also seen in this population. So again, not just the impacts of psychiatric illness, but also the health impacts of smoking and substance use as well get added to this. Next slide, please. So when we think about prescribing, right, I kind of think of it as sort of a Goldilocks and the three bears, right? You don't want too little, but you also don't want too much. You kind of want that like just the right amount. Because, oftentimes what happens is, particularly, those of you who may work in settings like nursing homes, where there's very strict regulations and guidelines regarding the use of psychotropics and mandated attempts at dose reduction or discontinuation. Certainly, those laws were written with good intent, with the goal of preventing over and inappropriate use of medications. But what happens is often that patients who genuinely need certain psychotropic medications, particularly things like antipsychotics for management of conditions like schizophrenia, schizoaffective disorder, will abruptly get taken off of these medications, and what you can see is a relapse of their mood and psychotic symptoms, and then which requires hospitalization, which can be very disruptive, particularly if it was avoidable in the first place. So again, you have to be very careful about how it's balancing staying in compliance with regulations, with providing and making sure that patients get the appropriate and indicated treatments. There's also sort of this balance between under and overdosing, right? And I see both extremes. I see patients who are way over medicated, both in terms of dosing, milligrams, and amount of medications. But on the other hand, particularly sometimes with antidepressants, I see patients who are undertreated or underdosed because their providers are understandably really tepid and shy about pushing up escalating doses of medication, even though such a dose escalation might be appropriate and really quite helpful in the management of the patient's condition, such as depression, for example. So again, it's sort of the Goldilocks approach of finding that just the right point of not too much, not too little medication. If you're going to discontinue a medication, do so slowly, particularly if you're dealing with sedative hypnotics like benzodiazepines. You want to be very careful and really want to avoid anything that could precipitate a withdrawal problem. Next slide, please. So obviously, too, we see the social impacts of serious mental illness, that there is a relationship that's been found between poverty and serious mental illness. There's sort of this interesting social drift versus social causation debate that goes on. So the social drift being that having a serious mental illness sort of causes you to sort of fall into poverty, fall into socioeconomic deprivation, versus social causation, where the idea being that social stressors, economic deprivation, institutional racism, things like that, are the actual cause of or contributors to serious mental illness. And I think in some ways there's a place for both of these. I don't think it's an either or. I think it's a both and. Also, too, what we see is that, again, this is not universal. This is not to say that every patient with SMI has these issues, but that the risk is certainly higher, that we do tend to see smaller social networks in isolation. Again, not everybody, but greater risk for housing insecurity, sometimes less consistent employment history. less financial wealth and security that has been able to be built up over time, and also stigma, right? That there, unfortunately, things have, I think, gotten a lot better over the years, but I still think there's quite a bit of stigma connected, particularly with having a serious mental illness, and the challenges which I think occur from navigating in our society with a longstanding psychiatric condition, unfortunately. Next slide. So also too, if we think about cognition and mental health, and really the two things are so interconnected that you really can't isolate them from one another. Often what we see is cognitive dysfunction is present in the majority of mental health disorders. And this is even not in the aged population, that when we look at younger cohorts, we see evidence of different types of cognitive dysfunction. The other thing that we often see is that cognitive symptoms, sometimes because they're more subtle, because they tend to evolve more slowly over time, and or because the patient may minimize or deny their existence, that oftentimes cognitive symptoms are overlooked compared to other symptoms, including depression, mania, delusions, and hallucinations. I see this a lot in my practice, where it's the sudden paranoid thinking and agitation that gets families' attention, and not, that family member has been missing bills or got lost. That again, sometimes some of the cognitive changes are so slow, and that the ability that the environment sort of adapts unconsciously to them. Whereas somebody who starts to have more acute and overt mood or psychotic symptoms, those kinds of things are often harder to sort of adjust to or dispel. So oftentimes it's not the cognitive, not the memory or executive functioning that brings people to our attention. It's their non-cognitive psychiatric symptoms. What we see in patients with schizophrenia, for example, we see deficits in working memory, attention, processing speed, visual and verbal memory, and abstract thinking. Again, these deficits occur outside of any neurodegenerative illness. And what's interesting is that Kalenda and colleagues, they found that amongst older women, those having a psychiatric disorder were twice as likely to be diagnosed with cognitive impairment compared to those without a psychiatric diagnosis. And also too, what we've observed is that both major depression and PTSD are related to a higher risk of dementia in the long run. So clearly there's linkage between mental health and cognition. And I often like to think of these as sort of neuropsychiatric, neurocognitive conditions because of the interplay. And oftentimes the first manifestation that somebody is having a neurocognitive disorder is so-called classic psychiatric symptoms. So things like anxiety, depression, delusions or hallucinations. Oftentimes that's what gets presented, that's what comes to our attention, rather than the cognitive symptoms that we tend to think of with classic things like Alzheimer's disease, Lewy body disease, other neurodegenerative illnesses. Next slide. So thinking about how do we adapt the CHA to this when we're working with these patients. So part one, take a very brief cognitive history of the patient. This history can be the response to an annual screening question. So a question that I like to ask is, have you or others close to you noticed changes in your memory or thinking? And the reason I include others close to you is because sometimes either the patient isn't aware or they don't want to acknowledge having cognitive impairment. And so sometimes it's emotionally easier, safer to put it onto somebody else to say, oh, I'm fine, but my partner is saying I always lose the keys in the house, right? So I find that perspective, that outside perspective, is really critical in any patient when I'm taking a cognitive health history, but particularly if you're working with somebody with as longstanding psychiatric condition. Or the other way to look at it is the observation of a sign of cognitive decline by someone else. Again, alluding, things that, again, I often ask about: getting lost in familiar places, missing appointments, misplacing items, particularly around the house or their living space, difficulty keeping track of medications, finances, or appointments. So again, all the things that sort of fall under the context of IADLs, right? If you have a patient who is still working, who's still employed, this is often where, because work presents a level of cognitive challenge and requirement that even more subtle deficits can get in the way. So the important thing in terms of taking the cognitive history is, what is the patient's activity level, right? How do they function? What's their day-to-day activity like? Because that will often give you an indication of how much cognitive impairment can they sort of get away with and still function, right? Again, most of us are working, even a subtle cognitive deficit would be quite noticeable compared to somebody whose lifestyle is much more routine and pared down. So thinking about the brief history, next. Looking at using screening tools, and again, there's a variety of different screening tools. An important thing about cognitive and functional screening tools is, I think it's important not to think of them as diagnostic in and of themselves. So, we shouldn't be equating an MMSE or a MoCA or a SLUM score with, X score equals X diagnosis. Rather, it's a snapshot, it's a view of how is this patient functioning cognitively at this moment in time, and recognizing that a variety of things can influence that score, not the least of which is their emotional state. So patients that are maybe very depressed or anxious could have their performance impacted, patients with a lot of attentional impairment, patients with low underlying IQ who may have underlying developmental disabilities, that's education level, that those are all going to impact these scores. And it's important to take that into account. Also, too, looking at screening tools with a partner, reliable informant as well can be quite helpful. Next. So again, just a couple of the different kinds of cognitive screening tools. Some of this depends on how much time you have. The general practitioner assessment of cognition is one. The mini cog is another. If I could only do one cognitive screening activity, it would be a clock draw. It's encompasses a lot of different cognitive domains. It's relatively independent of education and culture. Although I did have a med student a few years ago who was like, what's going to happen when everything goes digital and nobody knows how to read a clock? To which I said, hopefully I will be retired by that point, but you never know, right? But generally speaking, a clock draw is an easy and very efficient cognitive screening assessment. There's a number of ADL functioning, looking at activities of daily living. And of course, there's also a couple of others that can be administered to the care partner. And again, depending on your practice and time and the patient, looking at maybe some combination of screening tools. But typically what I tell folks is find a few that really work for you, that you can integrate very easily into your practice. Because that's the most important thing in terms of using them, is that an ease of use and a familiarity and comfort. Next slide, please. So again, looking at documenting the care partner information, right? So it's helpful to identify a care partner and document the partner's contact information, the records. Ideally, this person would also be a healthcare agent who has legal authority to make decisions on behalf of the patient if the patient were to lose capacity. But even if the cognitive and functional screenings are negative, it's still really important to ask about their support system. And I think about this in a strengths-based way as well. As an important strength or support. And if the patient can identify somebody, it's important to document that as well. Next slide. So if we think about, what are some of the challenges that we see in working with screening and identifying cognitive impairments in SMI patients, right? We've hinted at some of these, right? That non-cognitive symptoms can distract the provider from cognitive symptoms, right? If you have somebody who's talking about command hallucinations that are threatening and violent, that's going to grab your attention. As opposed to when you're facing those kinds of symptoms, how likely are you to then shift and say, well, tell me about your memory as well, right? Are you misplacing things, right? It's so often the more overt psychiatric non-cognitive symptoms can be a distractor. Not that they're not important, but that they can take up a lot of space and attention. Sometimes a lack of awareness of the patient's baseline, their symptoms and functioning, right? If you're meeting somebody for the first time and they start talking about hearing voices and hallucinations, again, could be a sign of an acute worsening of their psychotic illness, or it could be that this is a symptom that is relatively well controlled, that's there, but it's not intrusive, and that they've built a coping system around managing these symptoms. So it's important to get a sense of what is their baseline, right? What's their level of functioning? Again, patients who maybe have a persisting delusional outlook, worldview, but they're not acting on those delusions. They're not impeded in their overall functioning. So it's important to keep that in mind. Also recognizing just our own bias and the stigma that exists out there. Again, particularly related to notions of capacity and engagement, right? Having a serious mental illness does not automatically mean that somebody lacks decisional-making capacity or that they're unable to manage their own affairs. Sometimes too distant relationships with reliable informants and family, that can make things more difficult. Again, lack of a consistent, reliable informant. Also, again, as we talked about earlier, sometimes reluctance to engage with healthcare providers, perhaps bad experiences, underlying paranoia or suspiciousness, problems related to insight, particularly as it pertains to cognitive impairment. And again, also mistaking or equating a low score on a cognitive screening tool with a diagnosis of dementia, and not, rather than thinking of it as one piece of data that reflects where this patient is right now, and also disregarding the impact that active psychiatric symptoms and things like educational level can have on these sorts of cognitive screening tools. Next slide. So again, when we think of instrumental activities of daily living, I like to think of IADLs as the things you should be able to do when you go off to college, right? So these are things like using the telephone, preparing meals, hopefully some sort of household finance management, taking medications, doing laundry, doing housework, shopping, managing transportation. Again, all the things that one should be able to do to be a functioning adult. Versus BADLs, which are more like what I tend to think of, things that you should be able to do by the time you reach kindergarten: bathing, dressing, grooming, brushing your teeth, things like that. So one helpful, next slide, sorry. One helpful commonly used IADL scale is the Lawton. And again, this is an assessment that you can use. Next slide. So when do SMI patients come to our attention? Well, again, it may depend on what kind of practice setting you're in. If you may work in a setting where a lot of these patients are part of your practice, but oftentimes they come to our attention when there's a decline in their ability to function in their current situation, when there are new onset or worsening of non-psychiatric medical conditions, when we see an acute exacerbation of psychiatric symptoms, when these patients themselves become the victims of abuse, neglect, or violence. Again, there's also a lot of misperception and stigma around violence and mental illness. And what we see is that patients with serious mental illness are much more likely to be the victims of violence than the perpetrators of violence, and also high rates of suicidality in some of these patients as well. And also, unfortunately, when there are interactions with law enforcement. So next slide. So we're going to talk about a couple of cases now. I'm just kind of thinking about how do these sound familiar to you? Are these things, are these types of patients that you may have encountered? And how do we approach these patients? So next slide. So here's a first example. So Pat is a 68-year-old, presents to clinic with complaints of shortness of breath. She has a history of COPD, had previously smoked cigarettes and now vapes. She's had a history of schizoaffective disorder and is on Risperdal 3 milligrams at bedtime, Cogentin 1 milligram at bedtime, and Depakote 500 milligrams twice a day. She uses marijuana about 2 to 3 times per week. She admits to falling 4 weeks ago, was walking out in the street. She did go to the emergency room, but left against medical advice before a full workup could occur. She says that she couldn't stay in the hospital because she needs to receive instructions from God, and felt that the electrical equipment in the hospital was interfering with that. Her sister, who is her closest family member and reliable informant, lives in another town, but she has noticed that Pat has become more rambling and delusional in their weekly conversations, and Pat currently lives in a rented room in a hotel. So next slide. So how do you assess Pat, right? What are some things to keep in mind? So one is examining general health and functioning. What are Pat's major stressors right now, right? What might be going on that might be contributing to what the sister is observing, right? It's also important to be mindful of reluctance to engage with healthcare providers, particularly perhaps in the setting of chronic delusions. Again, already there's reports of maybe some suspiciousness or tying in being in a healthcare setting with some of the delusional thoughts. It's also important asking or assessing about delusions or such thoughts without either endorsing or refuting them, of trying to take a more neutral approach. So not directly confronting or trying to challenge the patient's delusional thinking, but also not endorsing it overtly. Of course, safety and suicidality are always critical. Looking at IADLs, looking at cognition, right? So taking into account possible distractibility, maybe limited cooperation, again, collateral information. Looking at medication adherence, right? Could it be that there's some difficulty with obtaining medication, or some side effects that have occurred and that's impeding, that's causing symptoms to emerge? And of course, what impact might the vaping and the cannabis use might also be having on Pat as well, particularly looking at coordination with marijuana use. So also, next slide. So also it's important to take a non-stigmatizing approach, right? What are the patient's preferences? Asking open-ended questions like, what are your goals for today's visit? A non-judgmental approach regarding substance use and medication non-adherence. So asking questions like, is there anything that makes it difficult to regularly take your medications, as opposed to, why aren't you taking your medications, right? Approaching the delusional thoughts rather than directly confronting them. One approach that sometimes I often take is, could you imagine the possibility that the opposite of the delusional thought might be true, right? Not saying you don't think it is, not saying they have to think it is, but just, could you imagine that, that you could still communicate through the building? What would that look like to you? Would that change things? Would that make you more willing to come into the hospital? Inquiring about treatment and personal history, right? Don't make assumptions based on a diagnosis, for example. Being mindful of balancing autonomy and safety, right? What is looking at the involvement of support system, and think about support system very broadly. And focusing on strengths rather than just the illness or symptoms, right? Oftentimes, in my experience, these are patients who have a tremendous amount of resilience and have really survived and even thrived in some ways in situations and settings that are often quite challenging. So focusing on strengths as well. Next slide. So I'm going to invite Dr. Chodros to join me here, but let's think about how would we have a conversation with Pat? How would we approach a conversation?
Yeah, thanks. It's a really obviously well, it's not that complicated perhaps, but obviously her presentation is, could throw you off. And because I only think about dementia all of the time, I'm sort of asking myself, this is someone who's getting older, has lived with this condition for a long time, has lived with these medications potentially for a long time. So I'm starting to think, when I think dementia, I think trajectory, is this a change? So, how am I going to get more information about, is this her baseline? Is this new? Are these medications what she's been on forever? And is there a reason to think that, they're affecting her differently, or that if they've changed them, if that's, maybe contributing to her symptoms? And what you brought up really made me think, which I wasn't thinking before, or like if I were just assessing her right out of the gate, I might not think about it right away. Is there just something going on in her life? And this is, is housing more unstable? Is something changed about a roommate situation, or she doesn't feel as safe where she lives? So those are all the things I would be thinking about. And if I could do a screen with her and try to get some of the tools done, like a clock draw and other things, is there a lot of these folks? I guess one of the good things about being in care for a long time often with these conditions is that they've had other assessments that we can look back on. So we have more objective trajectory information, if this is really a decline or not. So I'd be sort of hunting for that and trying to talk to other providers. This question you say, like, how will you assess supports and IADLs? A lot of time I'm assessing that with other clinicians and not, or like support, more formal support systems like hired caregivers or case managers and people who really know them and have worked with them for a long time. And I'm just kind of going down your questions because they're all so good. Safety too, I think I really worry that sometimes I don't have all the access that I would like to have to knowing about someone's safety. And you pointed out how vulnerable folks can be to either physical, psychological, or other types of abuse. And it's a cause for concern. And then, cognition, again, I just think, maybe her baseline's different and maybe her trajectory is really what would be helpful here. And I loved what you said earlier was so helpful. Like sometimes we need to really focus on function because that's what's giving us the signal. So I would be thinking as much about function as cognition when I'm doing the assessment and trying to do that historical comparison and looking back. So those were all my thoughts. How else could we approach Pat?
Yeah, no, Dr. Chodros, I think that those are great insights. And I really like the idea of thinking broadly about and utilizing other clinicians that you might have access to and that might be involved in the patient's care, right? Oftentimes, we can feel like we have to sort of go it alone and it's all on us. But if your patient has a case manager, for example, or you have social worker or a therapist, or even like occupational therapy, sometimes enlisting occupational therapy to get a functional assessment. Because that's, to me, functioning is where kind of the rubber meets the road, right? That's cognition and symptoms. It's, to me, almost like sort of the theoretical, but the concrete sort of real life interactions are in the functioning. How is this person getting by? And I think, again, that's where we have to suspend our own disbelief and our own stigma and bias that, again, a rented room in a hotel to us may be less than ideal, but perhaps that's what works for this patient. We want to, meeting the patient where they're at in a lot of ways is often very helpful, but also, like you said, I think I also like the idea of the trajectory, right? is this patient, in this moment in time, we may be able to intervene, maybe taking away the cogentin, for example, or reducing that, which may be causing some cognitive side effects. Or, if she had a fall, maybe, the dose of Risperdal doesn't need to be as high anymore. Maybe we can get by with a lower dose. Or is there some other drug that perhaps Pat was put on that may be inadvertently interacting with the Depakote and raising the Depakote level? So I think, one of the things is the hardest thing about geriatrics, and one of the things I love the most about is the complexity that's involved and the interaction of all these different systems. So, and thinking about, we actually have one more case to talk about. This is case 2. This is My Home is My Castle. So Robin is a 71-year-old with a history of diabetes, hypertension, congestive heart failure, and obstructive sleep apnea. Robin presents for an appointment. Concerns that Robin is in danger of losing her home due to an accumulation of items, including trash in her home and yard. Now, when you ask Robin about this, Robin says, well, I might need it someday. So again, concerns about possible hoarding disorder. Visiting nurses who had been working with Robin will no longer enter the home due to unsanitary conditions. So again, we're seeing a potential loss of a support and resource. But Pat is very adamant, you won't put me in an institution. I don't want to go into a nursing home. The home health agency social worker is worried about Robin repeating and forgetting about conversations. But Robin tells you there's nothing wrong with my memory. So if we think about kind of the next slide, the conversation with Robin, so again, taking a brief history, looking at screening tools, documenting care partner or collateral informant information. And this allows us to start a brain health plan at the earliest detection of symptoms, rather than waiting till something catastrophic happens, like Robin gets evicted from her home because of unsafe conditions, for example. So starting as early as you can with patients and really thinking ahead. Next slide. So again, when we think about treatment considerations, adapt to cognitive and functional status, right? Again, meeting the patient where they're at, thinking about their literacy level, respecting individual needs and differences, understanding values, recognizing the role that sensory impairment can play, vision loss, hearing loss, also being mindful of communication, access to technology, right? It may not, a patient who can barely operate a cell phone saying, oh yeah, message me on my chart if you need something. That may work for some patients, but may not work for others. Safety, of course, recognizing the unique vulnerabilities that exist in this population. Lean into strengths and supports, right? Again, we can get so easily distracted by symptoms and pathology that we ignore strengths and supports. Looking at the awareness of stigma and judgment, both from ourselves and perhaps from people that may be working with the patient, and also paying attention to new versus chronic symptoms. Again, thinking about timeline. Next slide.
And Dr. Huege, we do have to end. I'm sorry, but I think those were really good cases. And I just really appreciate how you reinforced how to apply the CHA. And it's clear that we would do it in the same way essentially, but we have this understanding, this background, this context that SMI really is, tied up with, as you said, so concurrent with other cognitive, symptoms and decline and other things. So I really appreciate you giving us this really robust understanding and pointing out how important it is as this population's aging. We do, in addition to this great information, we do have, we just want to make sure that people have our information for the CME so that it's in the chat. I want to make sure people get that, and we'll leave the webinar on for a couple more minutes so people can access that. We also really appreciate the questions and the comments, and somebody pointed out, I'll just wrap it up with to bring into the conversation, somebody pointed out that as more and more people are also using cannabis as well as other things that are available, it's getting more potent, some of the particularly active components, and that people are, sorry, I just want to make sure that information was up there. And but it also may be inconsistent. It's not regulated either.
Right.
So exactly, in terms of potency. So that was, I thought, a really good point. I really, really want to thank you for your time, bringing your expertise, and particularly like your compassion and clear love of caring for these patients and helping us to think about it. And I just welcome everybody to continue to explore our website, because this recording will be linked from there, as well as the content that you've shared with us, Dr. Huege. So thank you so much. Really appreciate it, and appreciate everybody's engagement with the Dementia Care Aware program. And we welcome any and all people to reach out so we can continue to support you in caring for people living with dementia, with serious mental illness, and everyone else. So thank you, and have a nice afternoon, everybody.
Thank you for having me.
Thank you so much.